To get started here, just want to welcome everybody. This is the American Indian and Alaska Native Mental Health webinar series. And today we have Dr. Dale Walker and Dr. Ken Winters here to present on cultural considerations for high-risk psychosis. This training series is brought to you by the National American Indian and Alaska Native Mental Health Technology Transfer Center. We are part of the MHTTC network, which also includes 10 regional centers, a network coordinating office, and the National Hispanic and Latino MHTTC. This project is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the content is developed by the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. We also want to note that we are currently working on additional certification options as well. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of the webinar, so please use the chat pod to share your questions and comments. We will address questions at appropriate points during the presentation. Our speakers today are Dr. Dale Walker, as I mentioned, and Dr. Ken Winters. Dr. Roger Dale Walker is a professor emeritus of psychiatry and professor of public health and preventative medicine at the Oregon Health and Science University, and he's the director of the One Sky Center, a national resource center for American Indians and Alaska Natives dedicated to improving prevention and treatment of substance abuse and mental illness for Native peoples. Dr. Ken Winters is a retired professor in the Department of Psychiatry and adjunct faculty with the Department of Psychology at the University of Minnesota Medical School. He's published numerous articles based on his research in the prevention and treatment of adolescent drug abuse and serves on the editorial boards for a number of journals, including the Psychology of Addictive Behaviors and the Journal of Child and Adolescent Substance Abuse. I want to thank Dr. Walker and Dr. Winters so much for being with us today and sharing your expertise on this subject. And I'll just pull up your slides a moment, and then I'll pass things over to you both. Okay. Looks like we are ready to go. And do we have Dr. Walker? Are you all set?
Yes, hi. This is Dale Walker. I'm out in Portland, Oregon, and it's a pleasure to be with all of you today. This discussion, let me see if I can go back here, is really the second phase of a discussion of psychosis in Native American communities. The first one was to look at first onset psychosis. This time we're trying to look at high-risk psychosis. Now, as you might imagine, as we started to look at high-risk psychosis, we wanted to look at the acquisition process by which people begin to have psychotic episodes. The hope there is to develop a prevention-intervention strategy to work with people who have psychotic behavior. Our learning objectives today is to gain an understanding about high-risk psychosis. We want to understand the benefits and challenges, for there certainly are many challenges in early detection and treatment of those at high or ultra-high risk for psychosis. We're going to understand the latest treatment approaches and discuss those treatment approaches as they might apply to Native communities. Now, the risk factors, as a review for all of us, is the question becomes: can a young person be reliably identified who is at risk or imminent risk of developing a first episode of psychosis? There are 5 points that we want to make in this area. Current research suggests that a combination of biological and environmental factors create a situation where a person is vulnerable to or at greater risk of developing psychotic symptoms. There's a number of brain chemicals, including dopamine and serotonin, that may play a role in how psychosis develops. A stressful event may trigger a psychotic symptom in a person who is vulnerable to those problems, like a first-degree relative of a person who has schizophrenia. Risk factors linked to psychosis are far from definitive. Caution is recommended in order to avoid false positives. Finally, it's important for the individual to have a thorough medical and psychological assessment to rule out any physical illness that may be a cause of the psychosis. To begin the discussion, too, it's also important to take a look at this from a native point of view. And while it's unknown, the prevalence and incidence of high-risk psychosis and psychosis in general it's probably similar to or maybe higher than the general population youth. And one reason to explain that it might be higher is the fact that there is a higher native health morbidity in native communities. If you look at the problems for American Indian communities, from alcoholism, tuberculosis, diabetes, accidents, poverty, all of these, including trauma, are elevated in native communities, and these are risk factors that might be a problem with psychosis. If you look at what the Surgeon General's report says, the American Indian communities have the same disorders as the general population, but a greater prevalence, a greater severity, much less access to treatment, and the cultural relevance is much more challenging, and the social context is disintegrated. Ken, that'll go over to you.
Thank you, Dale, and hello, everyone. Pleasure to join you all with this topic. I'm going to just provide a little background before we get into the core topic of high risk and ultra high risk for psychosis. Let's just review for a moment what do we mean by psychosis. The important thing is it does reflect someone who has very severe and persistent disturbances in multiple areas, thinking, mood, and behavior. And these are so serious that they impact significantly the person's functioning. And from a global perspective, there's several core symptoms, and at least one of these core domains are present in a person with psychosis, ranging from delusions, which are fixed false beliefs, hallucinations, which can, most of them are auditory, but they can be visual as well. Disorganized speech, and people also notice behavior is disrupted and shows a disorganized pattern, and then in some cases there's catatonia, a severe form of withdrawal by a person. Psychosis does develop in a person across phases. And the three main phases that have been discussed in the literature are these: a prodromal, acute, and then recovery phase. And of course, a person after recovery can unfortunately relapse and return backwards. But in the prodromal phase, symptoms are at the low end, low severe end. Things get, of course, quite severe and problematic in the acute phase, and then recovery brings a person back to normalcy or near normalcy. In the prodromal phase, which is similar to our discussion coming up about symptoms and characteristics of someone with high risk profile. But one way to look at it is that the person's starting to show early signs. Some call it subclinical, which means it's not clear yet whether these are leading to functioning problems or impairment yet. They also could be so subtle that they wax and wane. might show up some days and not other days, or during some parts of the day and then abate later. I've listed here 6 common early signs: reduced concentration, decreased motivation, withdrawal from friends and family, sleep problems, deterioration in functioning, and starting to show some unusual beliefs, or some call it magical thinking, which could be precursors to delusional thinking. Here's a weather metaphor for prodromal phase. This is stormy clouds. Looks threatening, and it may lead to problems. But as we all know, sometimes we see stormy clouds off in the horizon and we don't get a storm or a problem. But of course, it is a caution, because it looks like there could be some problems. The next phase where the disorder is present, or the acute phase, and this is where the symptoms emerge and they're quite serious. Here's 5 features of these symptoms: confused thinking, false beliefs, hallucinations, changed feelings, and changed behavior. As I mentioned earlier, these are so severe and persistent that they contribute to impaired functioning. And these do emerge in young people. So unfortunately, and we'll talk about it in a minute, how difficult it can be to distinguish true symptoms from perhaps normal adolescent behavior. But you do get the full complex of problematic symptoms in a young person when they're in the acute phase. Another way to look at these symptoms is broken down into what's called positive and negative symptoms of psychosis. Both sets are maladaptive. The positive term really refers to the presence and the emergence and display of problematic behaviors, such as hallucinations, delusions, disorganized thought, and nonsensical speech, and bizarre behaviors. The negative signs or symptoms represent a person not showing healthy behavior, so it's the absence of. And that can be reflected by flat affect, reduced social interaction, not having much motivation, or not showing any interest in what might be typical pleasurable activities for people, and catatonia, moving much less, and sometimes even not moving at all for hours. So both sets of symptoms can be present in a person with psychosis. Sometimes, though, you see individuals with a greater percent of the positive versus negative symptoms. This can impact decisions on treatment, as well as how quickly somebody's problems may be noticeable by relatives. Topics we will address throughout our workshop today. My meteorological metaphor continues. I'm showing you the tornado here. This is my reflection of how we could look at the acute phase of psychosis. Tornadoes are very severe. They're devastating. They create a lot of collateral damage, but they're also relatively rare, and that is the case for psychosis. Generally, estimates, even internationally, have shown the prevalence rate to be around 1 to 2%. But despite its low prevalence rate, of course, it's very devastating. And then there's the recovery phase, so-called post-disorder. And the good news here is that we're just learning a lot more about effective treatments that can bring a person into extended recovery periods. And these recovery phases for many individuals can mean that they can return to very effective and what might be considered high-level functioning in the home and in the community. And many of them can see an absence of any of the severe symptoms. And I got to show you at least one more weather photo. So this is one way to remember about recovery, that it does provide hope and recovery does work, and we're just learning a lot more about the value of various psychosocial and pharmacological treatments. I'm going to read you a quote from a survey from the National Association of Mental Illness, NAMI, and they did a survey of both individuals who suffered from first episode psychosis and their relatives. And here's one of their statements at the end of the report. Psychosis is a gut-wrenching experience. Individuals and family members fear relapse more than anything else. At the same time, a common theme in personal comments was the encouragement not to give up. Hold on to hope, love, and patience. Recovery is possible. I want to have a bit of a sidebar topic, and this is alerting you to the importance of when individuals are being assessed or diagnosed for psychosis or the high-risk variables that we're going to talk about. Among young people, we have to be careful to do a good job of trying to distinguish what might be normal adolescent behavior versus what could be signs and symptoms of a mental disorder. Many behavioral disorders can be confused with what might be considered normal adolescent behavior. I've listed here on this slide some common features of natural and healthy adolescent development, and there can be all of these characteristics. These are things that teachers and parents and mental health counselors will often see, and you have to distinguish whether these are normative or whether they might be signs of a clinical problem. But in my list, you can see I'm looking at positive, so-called positive behaviors, as well as negative symptoms. But this list is really reflective of what could be considered healthy adolescent development. Inattention, repetitive or distressing thoughts, difficulties thinking clearly, unpredictable and disruptive behaviors, rapid changes in mood, and functioning issues in social and academic settings. I show this list to parents when I talk about adolescent development and parenting, and I ask them if they see their teenager anywhere in this list, and when they raise their hand, as most of them do, I say, well, that's actually good news. Maybe you thought this was a worrisome list, but actually it's a reflection that you are likely having a healthy teenager in the home. So it is a challenge of trying to measure and detect high-risk symptoms for psychosis from what might be normal adolescent behavior. So what are some clues to help distinguish normalcy from what might be considered clinical problems? I have 4 here. Does the behavior meaningfully disrupt social and role functioning? So normal adolescent behaviors that might look problematic, but they don't disrupt in a significant way the teenager's social and role functioning. Are the behaviors persistent? If they are persistent, that's more of a clinical concern. Do the behaviors cause distress to the individual and others? Now, there's a lot of angst in raising a teenager. I'm talking here about distress that's persistent and extremely worrisome and doesn't wax and wane. And then an important thing is to consider context. Does context not explain or moderate the behavior? If it doesn't explain it, in other words, if the behavior is showing up across multiple contexts where you wouldn't think that issue would rear its ugly head, then that might be a sign of a clinical problem. But so often when we think of the teenage behaviors that give us some grief, there's usually a context to it that gives it some meaning and that actually puts a rational spin on that behavior.
Well, when you...
I'm going to turn to Dale now.
Okay, thank you, Ken. When you take a look at the progression in untreated psychosis, one of the things, if you step back and take a look at what happens in that episode, you get a disruption of critical developmental period. That's that adolescent part of cognitive development that we're talking about. If there's a reduction there, that's very, very important to know about. You also see a loss of protective factors for work, school, and support.
Our topic of high risk and ultra high risk psychosis.
Ken, can you hear me? Hello? Okay, I was wondering if I heard your voice and I wasn't sure I was being heard. So we all know that the progression of untreated psychosis is quite visible and important to know and understand. What we want to see, though, is a different picture in what development looks like. We want to see cognitive engagement in work and personal relations.
I can hear you, Dale, yes.
We want to see positive, powerful emotions and lower sensitivity to stress and social vocational support and a purposeful life. If you take a look at it in that way, you can begin to understand that if we can intervene early, it might make a difference in how these people are going to look 10 years down the road. This is a description of the burden of disease. It was done in 2013. And if you look at this closely, the purple shows mental and substance use problems. And between the age of 10 and 50, you can see that they're predominant in all other mental illnesses, and they're right up there with accidents and injuries to visible problem. So when we talk about adolescence, we're seeing lots of difficulty in this area. Now, if you take the accidents out and refine the burden of illness across age, you can see that between the age of 10 and 50, mental disorders, including addictions disorders, are quite powerful and visible. Actually, you might even begin to see where is the money for healthcare being spent. Do we spend that in the early years, or do we look at the ages beyond 40 for most of the healthcare dollar? And the explanation is clear that when mental health issues are concerned, we're really providing services for the middle age to the advanced age in comparison to the young people where prevalence is a problem for most mental disorders. So is there a rational understanding for the need for increased services? And the answer is yes. We can see that mental health disorders begin in adolescence. Early intervention models are being now looked at. As you know, in the last 20 years, there's been a revolution in medical and healthcare issues. We now look at prevention and public health in a very different way than we did 20 years ago. So these new ways of understanding how a disease is introduced and becomes visible is now much more on our mind, because we know that if we can prevent or intervene early, we know that we can save the cost and reduce the burden of illness. There is evidence for youth services. These are a group of studies that point out the advantages of intervening early in adolescence, working with young people with mental illness disorders. Kim, that now moves to you.
I have a feeling Ken is having some audio issues, Dale.
Ken, are you not on? If you're not on, I'll go ahead and move through here. When we talk about what high risk or ultra high risk psychosis is, we find out that it's really a mechanism to do an early detection for a psychosis that's about to happen. Some individuals, by virtue of possessing several risk factors, are at high risk or ultra high risk for developing a first episode. Now, a first episode will occur among 15 to 30% of high-risk individuals within 12 months and 36% over 3 years. These transition rates are several hundredfold above the general population. So they're beginning to refine this high-risk and ultra-high-risk strategy for problems. The main risk factors are family history for psychosis. That's especially true in a first-degree relative. Now, you all know a first-degree relative is a parent, a sibling, or a child. So if that happens in that group, that's the highest concern for psychosis in an individual. Can I be heard? I'm hearing feedback. Can you hear me? I can't hear anyone in discussion.
Dale, we can hear you. Don't think we can hear Ken at all.
Okay, I just needed to have feedback myself so I know where I am.
No problem.
Be
Keep going.
patient
We're working
with
on
this
it.
crowd. We're having some problems with the issues here. But family history is an issue for high-risk, ultra-high-risk psychosis. And then there are those attenuated psychotic symptoms, widespread cognitive deficits. Now, that's a very important statement when you look at children, because you're trying to look at poor school performance, unusual thoughts and suspicion and paranoia, low social functioning, substance abuse, and overall functioning difficulties. If you try to measure the risk factors, there are several structured or semi-structured interviews. I'm going to mention these, but if you have this talk, all you have to do is Google the names of these things, and you'll find out how to do the structured interview program. There's this structured interview for prodromal symptoms. That's called the SIPS, Comprehensive Assessment of At-Risk Mental State. The CHARMS, Early Recognition Inventory for Retrospective Assessment of Onset of Schizophrenia. That one sounds scary to me, but it's a good title. And Basal Screening Instrument for Psychosis, the BSIP. The BSIP is very popular in use and one that I'd recommend, as well as the CHARMS and the SIPS, as ones that you might want to refer to. There are signs of high risk that emerge in the teenage years. We'll look at this in a different way in a moment, but you can see there's something going on before the psychosis happens. That's important for you to understand, because those cognitive dysfunction problems and the way that children process their thinking leads to those negative symptoms that you see in psychosis. And that's withdrawal, feeling a little bit paranoid and uncomfortable, apprehensive. Those are the issues that you'll see in those early onset phases. This slide represents that in a different way. You can see on the top level there's preclinical, ultra-high risk, first episode, and relapse. We've discussed those and what might happen. For instance, childhood trauma, emotional abuse, physical neglect, and high perceived stress situations, traumatic brain injury. All of these can put a person at risk for psychosis. Obstetric complications are also a factor. When you go further and look at the first episode, you see childhood, adolescence time period, but there's unemployment, affective comorbidities. I'm talking about anxiety and depression, physical inactivity, social deficits. These things happen right at the start of that first episode of psychosis. So here's a listing of the ultra-high risk criteria for you to take a look at. On the attenuated positive psychotic symptoms, there's a presence of one or more of the following symptoms: ideas of reference, odd beliefs, or magical thinking. You've heard about these before. Perceptual disturbance, paranoid ideation. The frequency is at least several times a week, and the recency is within the past year. So these attenuated psychotic symptoms are important for you to take a look at. There's the brief intermittent psychotic episodes. These are called BIPS, B-I-P-S, and they're transient psychotic symptoms, presence in at least one or more of the following. Now, these are the true psychotic episodes: ideas of reference, magical thinking, perceptual disturbance, paranoid ideation, and odd thinking and speech. The duration is less than a week. So it's very important to understand and try to work with this person early on. We'll be talking in a moment about how to do that. The trait and state risk factors are schizotypic personality disorder and significant decline in mental state and functioning. I suppose that's something we really need to be thinking about as we go through this discussion, that the cognitive functioning and the ability to socialize and work with individuals are the first notable aspects of problems of psychotic behavior. Now, this is an example of how you might want to look at the premorbid phase, prodromal phase, and psychotic symptoms, remission, and relapse. Nowadays, we're trying to look at the onset as a primary prevention intervention. So we want to get to the problem before the duration of untreated illness. We want to look at the first psychotic episode as an important time to do secondary prevention, and then tertiary, with a T, not a C, is how we would look at the onset of the relapse over time. So those are the ways that we will take a look at the problems. Now, this slide is an illustration of the difference between traditional diagnostic approach on the left and the current dimensional liability approach to psychosis on the right. The diagnostic approach on the left requires cases to meet a specific criteria, and the analyses are done on discrete categorization of the sample so that you find out those who are not affected versus those who are affected. So that's really the classic medical model for looking at treatment. You do treatment when the person is affected and provide care at that time. This different liability approach really is a prevention-intervention model. It considers the continuous quantitative measures that reflect a risk for having or developing the disease. That model is now the popular model for working with psychotic episodes and how we can do a better prevention intervention. The best approach is indeed prevention and public health at this time. Now, this is a developmental trajectory model, and it's an important model in looking at prevention intervention. There are multiple indices of brain function that show age-related maturation and should provide early markers of vulnerability to psychosis. So you can see the typical developing healthy person in blue, and then they become a healthy adult over in the green. But if you are at risk for having a problem, that is noticeable about age 10 up to age 20. And so if you are at risk, that will help you in trying to define and develop an intervention that might prevent a psychotic episode. That's the goal as we talk about these issues. Here's an example of what happens with the symptom disability gap. The evidence demonstrates that there's a premorbid and clinical high risk for psychosis phase and psychosis, and impairments in social cognition are already observable. So if you look at this slide, you'll see the disability, which is the cognitive dysfunction, in blue, and the psychotic symptoms in green. So there's a gap that develops before the first episode of psychosis. And that gap becomes an issue for us to be concerned about. What you want to do is to target the blue, where the disabilities and cognitive function are occurring, and try to develop intervention strategies to work that through. The way to look at a psychosis development is shown in this slide. There's a pre-morbid period that we've been talking about, where there's mental impairment, and that shows attachment disturbances, dysfunction in the HPA axis, which causes anxiety and stress, and the dopamine dysregulation part. So there's increased anxiety and loss of control during this pre-morbid period. The prodrome shows abnormal explanations of social experience, as Ken was talking about early on, and states of heightened awareness. So psychosis onset really leads to a progressive deterioration in function in brain areas. So you can see why we want to look at an earlier intervention model for this. Very briefly, I'll just mention in this slide that early interventions are gathered together around cognitive deficits and negative symptoms and social dysfunctioning. You can see that those occur earlier in the prodrome area before the psychosis really reaches a heightened and diagnosable level. So the efforts obviously would be to target those areas early for prevention and intervention. I want to show a little bit of how one might look at developmentally sensitive interventions. There are two levels that I want to share with you. The first is the top on clinical risk symptoms, and the first one I'd like to talk about is the familial risk symptoms for psychosis on the bottom side. Those are the ones that we know the most about. Now remember, familial risk for psychosis means there's a first-degree relative with psychosis, and so that person is at risk. It's important that we look throughout that person's lifespan about how they're doing to develop a better treatment intervention strategy. That really occurs from conception, where you want to look at good parental care to reduce maternal infection and substance misuse, stress, and obstetric complications. After birth, you want to continue to look at good supportive parental care and early mother-child interaction support. Over time, you can begin screening for cognitive, social, motor deficits and prevention of trauma and bullying, etc. So, and I guess participation in sports, recreation, music, and art. Now, why do we want to do that? We want to really look at withdrawal from society, social problems, and difficulties communicating across with their peer groups. We want to also make sure that they have the absolute best opportunity for cognitive development and thinking, and assuring that there are less motor skill deficits. Later on, we want to emphasize avoidance of drugs, managing risk-taking, and pro-social activities. So, and how one forms an identity in those important times from 12 until 18 years old. Now, the clinical risk symptoms, those people who might be at risk that you've noticed problems in their functioning in elementary school that you saw down below. We develop support school function, family psychoeducation, support relationships, and cognitive enhancement. Ultimately, if the problem begins to express itself, cognitive behavioral therapy, family therapy, medication, supported employment, and clinical conditions would be very useful. Now, a long-term approach in this slide, and I share this just for your review, it's important to kind of take a look at what happens over time. Psychoeducation for both the individual and the family is critical at the beginning and could be an important part of what we need to do with the individual. Now, when you talk about psychosis, it's important not to project this as a life-ending phenomena, something that is going to affect them over time. We really need to not blame the person or the family or accuse them of having some weakness that has caused these symptoms. It's really very clear that if you can work with people in a positive way and develop a lifelong strategy of working with these problems, that you can improve their outcome. Why do you want to improve their outcome? You want to reduce the burden of illness. That's our goal in this process. You can recommend avoiding alcohol and drugs, cannabis. Very, very important to do that continuously over the lifetime of that individual. Reduce stress and strengthen social supports. Promote family functioning and daily living activities. I can't tell you how important it is to help our native families in trying to do these activities. I also can tell you how difficult it is, and we'll talk about that later, to work with native families and the people who are having difficulty finding resources and access to care. Ultimately, we want to look at giving advice for careers and trying to provide opportunities for people that fit and work with them well. Now, if you look at that system, what you're really looking at is a comprehensive network of care around the individual, one that will give family education and support, peer support, low-dose medication management if it's needed in the later stages, supported employment and education, and care coordination. All of this goes to a personalized coaching and therapeutic approach. Now, when we talk about cognitive enhancement, this model is the same slide really that I just showed you, except I wanted to share what we get out of it as a therapist and how we work with the individual patient. When you look at the individual psychotherapy, peer support, psychopharmacology, family support, integrated medical behavioral care, all of these substance abuse treatment and avoidance, all of these go into a cognitive enhancement that you present back to the individual patient and the family. So that becomes the method that you're going to use. It looks complicated, but frankly, for a therapist, this is the way that you can build a support system around the patient and their family. In summation, you can really look at messages and treatment in these 8 steps. You want to look at life function for the individual so that you can develop improved vocational preparation. Life fulfillment is a critical issue to avoid depression, frustration, anger, and anxiety. And CBT, that's cognitive behavior therapy, and motivational enhancement therapy are good approaches to working with both patients and the family. Financial stability is a target for all of us to be concerned about in working with and financial planning for the individual. These illnesses are very expensive, and trying to find a way to provide care and support with all of the arrangement of support and services around the person is a critical step. On top of that, developing fun, having recreation, art therapy, some expressions that give the individual a feeling of success and support are critical. Family and peers need the education. I'm a very big proponent of building mental health care education systems into school systems across Indian country. Physical health and public health is really a partnership that needs to work together. And then you need to focus on the other problems, anxiety, depression, PTSD, and substance use disorder. So then you can maximize the personal choice process with cognitive behavior therapy and motivational enhancement. Psychotropic medications, they're really not seen as a choice for ultra-high-risk psychosis. I can give you 2 reasons for that. First of all, there are many patients who are potential high risk for psychosis who will not have psychosis. So why provide antipsychotic medications for those people? The other is people who have this risk and don't develop psychotic episodes really don't want those kinds of medications to use. So medications are very, very conservative in working with this population. Ken, are you on? Can somebody help me? Are you hearing this?
We
Yep.
are. I talked to him.
Go ahead, Megan.
I talked to him on the phone, and he said he was calling in, and he could hear everything, and he could talk, but
He's calling in. Okay. I just have to unmute if he's calling.
yeah.
Wait, then 1 second. Oh, this is.
Forgive the interruption here.
Can you hear me now?
Oh, yes.
Yeah. Okay, I got my computer to work. Excellent.
Great. Yeah, we can hear you.
Thank you. Sorry, everyone, for having a little audio problem. The next set of slides is to give us some insights about a important phenomenon that is related to likely the trajectory of risk toward psychosis and very important in recovery of it. And it's a concept that's valuable to teach to parents and caregivers, all those in the home and the local surroundings of an afflicted individual. And it's also an important set of principles for staff when treating those that are either at ultra high risk or are showing first episode psychosis. And this concept I'm going to be talking about is expressed emotion, or EE. And maybe you've heard about it, but it's really a form of shaping communication style among individuals affecting and influencing the individual, the teenager and the high-risk individual in a way that helps minimize symptoms, minimize negative trajectory of their problems, and likely increase recovery. So the basic elements of EE are 5 different emotional types expression. And on this slide you see 2 columns. We're back to 2 different themes here, dichotomizing. There's considered the, on a negative side, if you show high degree of these 3 emotional states, hostility, over indulgence, and being critical, those would be considered a form of high EE, which you want to avoid. On the other side are these are positive themes, but if you actually show them at a low level, these are also considered to be non-favorable. So low levels of warmth and low levels of positive regard would be, again, one of an EE type that you want to correct. So the opposite of all these 5 would be the favorable kind of expressed emotion. So you can look at this as really a dimensional topic, where at one end the emotions being expressed are considered to be we'll call them unhealthy or promoting risk, and and not promoting recovery, while at the other end they're more favorable, they're healthy, and they would be promoting recovery. A little more details about all of this. So why is EE important? It maybe is logical that this would be related to people's health, but there's been a lot of research in the schizophrenia arena looking at this, and perhaps over 30 years of research. I heard one expert on the topic a few years back say that there is so much research on this, and it is so consistent in the same direction that it doesn't make sense to spend any more time or money on additional research, because the basic findings are quite reliable. A summary statement is at the bottom of my slide here that I got from 2 articles, so I'm collapsing across these 2 articles. But approximately, for those individuals, afflicted individuals, also with psychosis, if they're in a family with high EE, so that means they have too much of the negatives and not enough of the positives, the relapse rate can be around 50%, as opposed to all the way down to a much better relapse rate of around 20% in families that have low expressed emotion or that are showing all the favorable traits. And all of these rates would be more pronounced with individuals that are chronic cases. And when we think of first episode psychosis, those individuals might be on a chronic course, and so it speaks to the importance, enhanced importance of the role of EE with first psychosis. Just to show you how dramatic the difference can be in outcomes based on whether it's favorable expressed emotion or not. There's several lines here and charts. I put a red box around the one that's perhaps the most dramatic in finding. The solid line represents families where the psychotic individual was in a home with low expressed emotion or favorable, and the dotted line is showing the group of individuals that were living in a home with high or unfavorable expressed emotion. You can see the relapse rate from 6 months to 1 year was very different, and even the 1 year rate even goes down quite a bit, as opposed to, unfortunately, going up in the high expressed emotion group. So a dramatic way to make my point that this is a key construct. If we look at what are the reasons why this is an important phenomenon, these are 4 that the experts talk about. You can imagine that when emotions are running hot, let's say, in communication, or when there's fear that emotions will be hot and too expressive in one's living environment, this can lead to a lot of extra difficulties for a person. And someone's already dealing with all kinds of emotional and cognitive impairments. This further aggravates their symptoms. And so when there's high expressed emotion, or the negative type, unhealthy type, you get impairment in the ability of the person to cope with everyday issues. It most likely contributes to social withdrawal, and that further compounds perhaps coping. And you can imagine that because it overstimulates the patient, this creates a lot of negative moods and further aggravates their views of living at home, and they might also then start to believe that their family is not very supportive of themselves and of their health issues. Of course, without family support, this is going to further dampen someone's ability to have a helpful or healthy course of their disorder. A lot of people have looked at expressed emotion as not only being part of the onset of psychosis, but surely contributing to the cascade of other consequences and components that contribute to then expressing positive and negative symptoms. So at the top you see under triggers included, in addition to stressful life events, is being in an environment with high expressed emotion. And with that interacting with certain biological risks, and that then also contributing and interacting with social and functioning, cognitive and behavioral functioning components, that can surely accelerate somebody towards this adverse outcome of psychotic and psychotic-like symptoms. So a little more detail about the 5 features so that you can get a feel for the kinds of things you'd want to educate family members as well as your staff. So remember, there's 3 of them: criticism, hostility, and emotional over-involvement. When they're at the high end, that's bad news. And when there's an absence of warmth or absence of positive comments, that's also in the bad news direction. So briefly, what are we talking about with these 5? And they're very logical. They fit our basic understanding of these terms. But specifically, reminding caregivers the comments about the behavior or characteristics of the patient, which might be viewed by that patient as resentful or annoying, is something you want to reduce. Not having a lot of criticism or perception in the family that there's rejection of the patient. An interesting one for some is this over involvement emotionally with the client. It's probably quite logical that someone who cares about an individual will actually try to help them a lot, and sometimes that can go overboard. So the notion is when self-sacrifice is excessive, or when the person is extremely overprotective, and in getting over-emotional about the difficulties that the patient is experiencing, all can lead to this really a negative form of over-involvement. So that's one concept where it's really, it can't be, of course, too hot, can't be too cold, because then you have number 4, which comes into play if there's an absence of warmth. And so this would take various forms, both behaviorally and emotionally, where there's lack of kindness, concern, and empathy from the caregiver. And the last, which is an absence of positive comments, you can imagine you have to try to avoid all the negative comments that might reflect somebody's difficulty in dealing with a son or daughter that and relative that has significant functioning problems. But the idea is you need to take a strong step and proactively make sure there's a lot of appreciation and support that is offered and verbalized on a daily basis to the client. So 5 things for caregivers to be on the watch for. And so the idea is to, as you can imagine, you want to decrease the criticism, hostility, and the emotional over-involvement, and you want to increase the warmth and positive comments. So below, I have 7 specific behaviors that are taught in this with this concept in mind. You can see that they really fit, what might be thought of as motivational enhancing type communication style. Staying calm and being patient, asking questions, and not rushing responses. Being a good listener. I also like the one about using I statements. So this means you're not placing and pointing blame on the patient, but the caregiver is realizing that they need to just own up to the feelings they're having, but it surely can help diffuse a lot of guilt and can help move discussions along. Of course, quite logical, avoid name calling and recognizing your own limits. That is recognizing the limits of the caregiver of how much they can help a person. So offering advice, being a good listener, but knowing that you sometimes can't control everything is an important principle. A couple other features that are talked about by the experts. One has to do with the issue of how much direct contact one should spend with the patient or the family member who is suffering from psychosis. And they're in an effort to make sure you don't get over-involved emotionally. There's this principle about trying to make sure the direct contact you have with the afflicted person is less than 35 hours per week. So think about that per day. Some days more, some days less, but the concept is not to discourage the coping abilities and the need for the afflicted person to gain independent skills. And another feature is to make sure you, as the caregiver, impress upon the patient that they do have self-efficacy. Interesting concept, synonym would be self-accomplishment. As many of you who've taken motivational interviewing training know that supporting self-efficacy is an important motivational enhancement tool. And by this feature, you are encouraging and giving support to the person that they can accomplish, that they have coping skills, and they can affect behavior change in their environment, and that they don't have to be 100% or fully dependent on people around them to help control and maintain a stable environment. As you might realize, the earlier the better that you can educate caregivers about these concepts of EE, the more likely you're going to be able to impact positively the course of that patient's disorder and likelihood of recovery. Another thing I like about EE is that the idea is that you're going to really look at this whole topic of somebody with a serious disorder, not from a negative standpoint, but from a strength-based standpoint. And so building in how the patient can capitalize on their strengths and interests and not let the difficulties that they're experiencing get the best of them is so important. As you can imagine, that builds self-efficacy, builds coping strategies, and broadens the social development of the person. A reminder that the issue of expressed emotion is relevant to treatment setting and staff. It would make sense that this concept is important when staff are dealing with patients, and that the general environment of the treatment setting not show high EE would also be important. It's logical, it makes sense, there's limited evidence. It's probably because it hasn't been enough resources to study this topic, but indications are that clients do respond favorably to the low expressed emotion and respond unfavorably when it shows the level of it at the negative end. So think of all of the strategies you're going to teach the caregiver. These are also communication and contextual issues to keep in mind with your own behavior and the treatment setting. My last point about EE, it may be related to the course of other disorders. A small literature, but perhaps the Most significant is the link between EE and a course for depression, bipolar disorder, and eating disorder.
Well, the important thing, too, about expressed emotions is the impact that family and peer has on an individual. And engaging their involvement in any type of recovery plan is critical. And I think that that nice review of expressed emotions helps me with that point. I wanted to start closure of our discussion by bringing up some information that NAMI, the National Alliance for the Mentally Ill, has gathered on the onset of early psychosis. It might be interesting for you to kind of see this information in a way it's presented to the group. And the first question was, who first recognized the symptoms of your early onset? So these are people, about 1,215 people were interviewed to give this information. And who recognized it? The patient did. So they recognized that they were having symptoms. It's interesting, the next level is the family. The other is peers and friends in different settings. First responders, police and emergency services. That was more visible than physicians or school teachers. And I think that's kind of interesting that this is a very personal process. And people to recognize that, you know, you have to go to the source, in other words, the person. They begin to realize that their thinking is clouded and not comfortable. That's why you see people withdraw and become kind of isolated from their peers and friends. And it's important to talk with them if you see that kind of behavior, both in the family and in the school. When you ask the patients who was the most helpful to you, the very interesting answer, no one, was the winner. Parents were next in line, and psychiatrists, psychologists, social workers, spouses were kind of in that other category. But once again, we expected to see co-workers and teachers and people in the early school years to be much more aware and helpful in making referrals. But it's clear that these people feel alone, and somehow prevention intervention programs need to be sensitive to this, getting information out into the schools. That's why I'm a proponent of bringing mental health education into the school system so we can help teachers with this process of being aware of what's happening. Now, I wanted to conclude the discussion by talking about suggestions for people in psychosis by individuals who have experienced psychosis. This is again part of that survey in 2011 by NAMI, and their advice is rather interesting about it. Find the right doctor, keep appointments, and take your medication. Find your spiritual strength. Know what triggers your psychosis and avoid them. Learn stress reduction and management. So you can see they're starting to get into the cognitive behavioral trigger and stress reduction management approach. Keep a sense of humor. See a doctor right away if it starts reoccurring. Get cognitive behavioral therapy. There you go. That's a nice direct statement. Be selective about whom and what you tell, but stay connected to others. Do what you can incrementally. Do puzzles, read books, do yoga. Don't look back, move forward. Take care of all of the areas of your life: sleep, diet, spiritual and social needs, and relaxation. Listen to or read stories that are positive role models for you as you grow up. And learn to trust and cooperate. Don't fight. Those are the things that you see, and it's interesting when you talk to people who have actually experienced psychosis about what they think would be good advice for a person who's about to step into this arena. That concludes our discussion. I know that we have time for questions, and indeed we have an important first question right off the bat from one of our people, and that is in Native American populations, how do you distinguish psychosis from a spiritual event? And Ken, I'll go ahead and answer that. I've had some experience with this, and indeed, when I hear the symptoms of whatever event they're telling me about, whether it's a spiritual scene or some type of, if you will, auditory or visual hallucination, first thing I want to do is to see how it fits in the story that the person is telling me. Then I want to talk to the family about, does this sound like it fits with what you know this person growing up and also what you experience in your family? Ultimately, I might want to ask a medicine doctor and I'm talking about a medicine person of the tribe, to try to help me understand. I think that the question is a very good one that always needs to be asked, is in my way of thinking, is it real or is it not real? And so we want to try to take steps and not assume that a hallucination is always a hallucination. There are other things that might be events that might be showing themselves in a special way, and we need to appreciate that in Indian country. My way is to look at the situation of the individual, in the family, and then the community, and how might this fit, and deal with it in a direct way. We don't want to kind of think of these hallucinations as just being quote-unquote crazy. That's not the way we want to think about hallucinations. And it's no use in getting into good and bad, sometimes persecutory hallucinations that tell a person that they're no good or they're doing the wrong thing in a continuous way. They need to be investigated for a thorough understanding of how that person understands the voices or the visual thing in their worldview. I hope that answers that question. I want to thank you all very much for your time here. We do have time for questions. Don't hesitate to start writing those down in the chat box, and we'll see what we can do to kind of move things forward. We've set up special time to talk about this issue, and I hope that you won't hesitate to talk with us. Ken, do you have any final comments?
Yeah, Dale, this is Ken. I wanted to ask you if something you might have seen in the NAMI survey report struck you as interesting, and we can maybe remind people about this survey report that's quite interesting. Remember, it was surveying those that had suffered from first episode and their caregivers and parents. But one of the questions was to the extent to which the individual and the parent thought that substance abuse was related to their psychosis. And the overwhelming majority in the survey said no, which I thought was interesting and maybe reflecting how we're not fully educating the public and young people about the potential that, while maybe drug abuse doesn't cause psychosis in any without many other risk factors, but it looks like it may contribute to the risk of psychosis and maybe even alter the severity of somebody's downstream disorder. Particularly the marijuana question comes to mind, given now there's growing evidence that's linking marijuana to mental disorders. Didn't know if you had any thoughts on that.
Well, I think that indeed when we're trying to understand psychosis, the complexity of other drugs in relationship to the problem, other kinds of difficulties, severe depression can be a very, very concerning problem. And people who have historical trauma, who are trying to deal with problems in their life, you can see how these things can drift over into a psychotic nature that's not really leading to schizophrenia, but other kinds of psychiatric problems. And so, in a way, when we have people who are at high risk, it is so important to try to get at the other things that might cause problems. Alcohol, drug use, especially marijuana, these are no-nos, and we need to kind of sidestep them if we want to have protection of the individual. I think that the NAMI questionnaire, what I liked about it was that, there are a lot of things that we don't know if we're providing care, and the family is experiencing them in a very different way than we understand. And that always tells me that we need to invite the family into the discussion early. We need to listen carefully to find out what we can do in working with this whole system. If you noticed in our treatment today and our recommendations, it's an incredibly complex process. And those of you out there in Indian country know that it's almost impossible to do everything that we recommended. But you can put together programs that will kind of knit together a response to help support and help a person along the path. I think that's the best advice I could give anybody who's working with high-risk psychosis in families out in Indian country.
Yeah, I want to just emphasize that you said the word support several times, and that's so valuable. It always doesn't mean it's going to be high-level, professionalized cognitive behavior therapy or even pharmacological treatment, because sometimes that can be difficult to find right away, and there are barriers to access to that kind of treatment. But caregivers, school teachers, community leaders offering support in very logical ways really can be quite valuable to a person who's got some early signs of maybe a path towards psychosis.
Well, we might even think about what would happen in Indian country before Western medicine was there for people that might have this kind of psychotic episode. They were really seen as special, and they were allowed to be a part of the community, to live and be supported, to find jobs and functions that they could do. And you know, that attitude and that history of American Indian people, I think could be considered a part of the process. It's not just a one-way path for treatment. You really do need to rely upon the community to provide the care, and in a way, historically, that's the perfect step in Indian country.
Yeah, yes. Well, and any time a home or a community can minimize the functioning disruption if somebody's experiencing high-risk symptoms, I think that bodes well for the long-term outcome of a person. Because not only do you have to worry about the severity of symptoms, but then the person finds that this is disrupting and impeding their ability to function, and that just further creates more stress and difficulties. But environments can adjust, and in ways that can help, optimize level functioning for people that might need certain adaptations, and that I think can be so therapeutic.
I think that's well said, Ken. The issue of informing a family that they don't have to be afraid of some of this behavior or
Right.
try to somehow overpower and make it go away will be helpful. Your comments on expressed emotion, I think, make that clear, that sometimes helping a person find comfort and ease is a better way of dealing with these early problems. If you try to fight and make them go away or control, that will increase the anxiety and maybe elevate to a higher level than you would have if you didn't do it that way.
Right.
So I think that's very important and a good point that you make.
I read several examples in the literature of how people used I call common sense to help in the recovery path of a high-risk individual. And so often the examples involved music and sports, and getting a person to get outside their shell, capitalize on something they might already like to do, but encouraging them to do it even more, looked to be so therapeutic. And in some instances, as you can imagine, it led the person also to expand their social network, because now they had something to do with others and could now feel like they were part of a peer community.
Maybe one of the things that I didn't mention in this discussion is that when an individual has difficulty with pre-psychotic behavior and tipping into psychotic behavior, that person is also a potential risk for suicide. And one might want to keep that as a treatment person in the back of your mind, wanting to know the status of the individual and how they feel about what's happening to them at the time. I think that we can do a lot, again, by prevention intervention for risk for suicide in these cases. And so if you're dealing with a psychotic behavior onset, it's important to take a look at some of these negative outcomes that could happen, and indeed you want to be very careful about that and help the person through by reassuring them that things will get better and that there's a good road down the way for them, as opposed to kind of the idea of being helpless or hopeless. When you see that, it's time to act on suicide prevention intervention.
Yeah. Good point.
Well, thank you so much. Sorry, I don't want to, if there are any other questions, I want to encourage people to submit them, but I don't see any other questions at this time. I certainly welcome Dr. Walker and Dr. Winters to share additional thoughts. But while we're waiting for any other final thoughts, I just wanted to remind everyone that we are recording this, so we will be sending out an email to everyone who attended, and it will have a link to the recording as well as copies of the handouts, and it will also have a link to the survey that we'll be redirecting you to after we finish up today, in case you don't get redirected there. And yes, we would encourage you to pass this on to your colleagues, or share it with anyone that you think would benefit. And yeah, I just want to thank you all for joining us again today, and thank Dr. Walker and Dr. Winters. And yeah, I just want to let you say any final thoughts yet before we finish up. And again, just want to thank you.
I too just want to say thank you, and Ken, I appreciate working with you on this project. It's always good to work with you, and I'm sure we'll be doing more of this in the future. And all of you in the audience, I hope that you indeed will feel comfortable in contacting us, trying to do follow-up and further questions. I much appreciate all of your presence.
It might be a good time to mention to everyone there will be a newsletter coming out focusing on this topic, and I'll make sure in the newsletter that the link to the NAMI survey results is provided. It's a free PDF download. I think you might find it interesting. We showed a few of the slides, but there's a lot in there that I think provide valuable tools and insights when you're not only working with a patient, but also with family members.
Wonderful. Yes, thank you so much for mentioning that, Ken. We will be having another mental health newsletter coming out in the next month or so, I believe. And so if you're, I'm guessing if you're on this webinar, you're on our listservs and you receive the notice about this webinar that way. We send out the notices about our newsletters the same way, but feel free to get in touch with either Megan or me. Megan's email is here in the notes, and I'll put mine in the chat here as well. But we would love to hear from you. And again, I just want to thank everybody so much for joining us today and for being interested in this topic and thinking about those who are suffering from psychosis and to get more training on that. So I really appreciate all your work and for joining us. And with that, I'll close us out for today. So thanks again.
Goodbye.
Thank you. Bye.